to answer that question, you have to have a little bit of historical context for how we've treated cancer over the past couple of decades. So historically, when we saw a cancer patient, we were often very binary. We used to say, we still do in a sense, but we used to often say, does this patient have localized disease, which would be amenable to a cure if you use something like radiation or surgery to locally treat the disease, versus does this patient have metastatic disease? And in those situations, we generally say that a patient is now incurable. And when we find a patient to have metastatic disease, we've historically felt that the benefit of a local therapy like radiation or surgery is not as great. And we typically default to treating patients with systemic therapy. So given that the fact that the cancer has metastasized and spread throughout the body, we want to give a therapy that can also go throughout the body. And historically, that's been chemotherapy. Now, in the past, I would say 5 to 10 years, there's been a strong interest in looking to see if we can be more aggressive with these patients who have metastatic disease. So in addition to treating them with systemic therapy, is there a benefit to now integrating local therapies like surgery or radiation? And that's where metastasis-directed therapy has come into play. And the reason why metastasis-directed therapy is probably now showing some benefits in patients who have metastatic disease, there's probably a couple of reasons. One is I think that our systemic therapies have improved. And now the importance of locally controlling metastatic disease has become more important now that we're able to, on a whole, control metastatic disease much better with systemic therapy. That's number one. And I would say number two are advancements in our technology when it comes to radiation. So historically, we would have to give small doses of radiation every day over many weeks to reach a radiation dose that is efficacious. But now with things like stereotactic ablative radiation, we can give very high doses over few treatments. And that biological effect is probably even better at controlling cancer. So there's probably this historical context of the way we thought about cancer a couple decades ago versus now, in addition to the technological and scientific advancements that we have really led to this avenue of metastasis-directed therapy, which is targeting metastatic sites with an aggressive local therapy. We used to think about cancer as very binary, either it was localized or it was metastatic. We now realize that that cancer is a very large spectrum. So on one end, you can have a patient who has just localized disease, amenable to a curative therapy. And on the other end, you can have someone who has widely metastatic disease, who might have 50, 100, 150 metastatic lesions. But in between these two ends, there are probably many different states. So you could have someone that comes in with metastatic disease, but that person only has one metastatic lesion. And we're now beginning to understand that someone who has one metastatic lesion is very different than someone who might have 50 or 100. Historically, we treated them all the same way. They just received systemic therapy. But now, really, the metastasis-directed therapy has sort of initially been integrated in these patients who have one metastatic lesion, because we postulated, well, maybe that patient, if you think about cancer as a spectrum, who has one metastatic lesion is much more closer, would behave much closer to a patient who has localized disease as compared to someone who has 50 or 100 metastatic lesions. And what if we sort of use some of the treatment paradigms we use in localized disease in these patients who have few number of metastatic lesions, which we call oligometastasis? So the spectrum theory of metastasis essentially realizes that there are many intervening states of cancer, and that thinking about cancer as just a purely binary state is probably not the optimal way to go about things. And by thinking about this as many individualized states, we can now take all the different cancer therapies we have available to us, surgery, radiation, systemic therapy, and integrate them in an individualized way for each specific patient based on where they lie along the spectrum of metastasis. Within prostate cancer, there are a couple of prominent and important studies of metastasis-directed therapy. Two of the early ones were the STOMP and the ORIOL trial, which took patients with hormone-sensitive oligometastatic prostate cancer defined as 3 or less lesions, and randomized these patients to either receive metastasis-directed therapy, typically with radiation or SABR, versus just observation. And what both of these studies showed in similar patient cohorts run at separate institutions is that the addition of metastasis-directed therapy prolonged the time to progression and also delayed the time to need to initiate androgen deprivation in these patients. And so these two individual studies that studied similar cohorts of patients actually showed very similar findings of benefit for these patients. Recently, within prostate cancer, there was another very well done study run out of Italy that took patients with castration-resistant prostate cancer, which is a very different biological entity, and took these patients and treated them all with abiraterone, and one arm received SBRT while the other arm received just abiraterone alone. And these initial findings have showed that the addition of SBRT also improved progression-free survival in this cohort of patients with castration-resistant prostate cancer. And so within prostate cancer, I think we're starting to accumulate more and more evidence that the use of metastasis-directed therapy can become very effective, and it could be applicable to a wide range of patients. Both the STOMP and the ORIOL trial reported on toxicity when using metastasis-directed therapy, and the toxicity rates were very low. And I would say that's sort of in line with my own clinical practice, where when I see a patient, I tell the patient that I would say probably about 80% of people have minimal to no side effects with this form of metastasis-directed therapy using SABR, given how highly focused it is. And so patients tolerate the treatment very well. And that, in combination with its effectiveness, makes it really enticing to patients, especially after they've been treated once. They'll often say if they ever have to go through another treatment, that it will be a great option for them to be treated with this modality again. And so it has been shown to be very favorable from a side effect profile using this really highly conformal radiation technique of SABR. There's actually a bunch of different trials within the genitourinary space that is looking at metastasis-directed therapy. So within prostate cancer, there are several other ones that I think will give us a lot of really important information. So for example, the NRG is running NRG-GU011, which is looking at metastasis-directed therapy with SBRT with or without a course of androgen deprivation therapy. And so this is starting to look at how do we best integrate the combination of systemic therapy and metastasis-directed therapy, because there could be a really strong synergy between the two. So we have lots of different options available, and now we have to figure out how to combine these to optimally treat patients. So I think that's one very exciting study that's enrolling, will give us a lot of information. A lot of these studies that I've talked about have been what's called within the metachronous space. So that's a patient who received definitive therapy and then unfortunately had a recurrence of their tumor. So both STOMP and ORIOL enroll patients like that. But there's also the question of what's the role of metastasis-directed therapy in patients with de novo or synchronous metastatic disease. Those are patients that have metastatic disease at their initial diagnosis. And so the TERPS trial, which is being run out of University of Maryland, is looking at treating patients with radiation to the intact prostate, which we know from the STAMPEDE clinical trials showed a benefit in patients with low volume metastatic disease. But now is also looking at what's the benefit of, in addition to treating the prostate primary, using metastasis-directed therapy with SABR for the metastatic lesions. So that's another ongoing study in the prostate space. Within the kidney space or the renal cell carcinoma space, it might not get as much attention, but there actually are several trials that have actually been reported showing that metastasis-directed therapy can be very effective in patients with renal cell carcinoma. And so there are multiple studies that have prospectively looked at patients and treated patients with SABR to their metastatic lesions in renal cell carcinoma, and shown that the time to development of a new metastatic lesion is actually fairly long, And the time to either need to start a systemic therapy or change a systemic therapy is actually pretty prolonged after SABR as well. And so renal cell carcinoma represents another space that's being looked at and probably even right to expand upon, given some of the initial encouraging data for metastasis-directed therapy in patients who have metastatic renal cell carcinoma.